going to move on to our clinical topic with our good friend, Dr. Tim Kosinski. Dr. Kosinski is a highly sought after speaker and teacher in the world of implant dentistry. He has taught hundreds of courses and written dozens of articles. But I think the most important thing is he has been a mentor to many dentists as they enter the world of implant dentistry. He's the editor of General Dentistry, which is the official journal of the AGD. And his topic today is immediate implant placement after extraction. And he's going to talk all about extraction techniques, grafting, and immediate placement. So, Tim, I am delighted to turn this over to you.
I hope everybody can see that fine now. Well, thank you, Dr. Park, and the beginning of these programs, I always learn so much. Thank you all. I'm trying to think of my taxes and CE plan for everybody. And as you know, I sent my staff out to the IO program with Glidewell, and I was very, very much appreciated. They came back with a lot of enthusiasm for milling and scanning, and so we're very excited. So I always appreciate the opportunity to share some of my clinical experiences. As you know, I'm a general dentist in Detroit, but we do a lot of dental implants, and setting the foundation for our dental implants is so important. I like to say in my courses, threading a spark plug into the jawbone is not the hard part of implant dentistry. It's understanding, designing, understanding anatomy, and creating the foundation for the final result. Personally, I don't make the final white teeth that are in the mouth. The team at Glidewell does. Alicia, the technician there, is so excellent in designing and providing the final product. But I'm proud to say that I do give her a platform to create the exceptional work that she's able to provide. So our topic today is the immediate dental implant, and this is interesting case presentation. This is northern Michigan. We have a house up on Lake Michigan, and it's just a beautiful state for those of you who have not visited. It's my therapy area. We work very hard when we're here, and every opportunity I get to settle down and collect my thoughts, it's up there in the sunrises and sunsets up in northern Michigan. Our learning objectives today are going to be really clear, really practical. Atraumatic extraction, that's a term that I coined many years ago, and I was criticized for that many times early on, but I do see that term being used by other speakers now. When I'm talking about atraumatic, minimally traumatic to the patient, providing a technique where the patient doesn't experience a lot of pressure and discomfort. Taking a tooth out is emotional for the patient. It's mentally emotional and physically emotional for the patient. So we try to make it as simple and easy, and I'll demonstrate that a little bit this morning. But also atraumatic to us. Many of us have neck, hand issues, and learning a technique where you can save your body, save your hands, a technique where you don't need a lot of strength to be able to provide these services, I think is really important. I'm not going to try to sell this technique or product, but it's something that I use in my practice literally every day. Saving our body is very, very important. We also want to preserve as much bone as possible. I have the philosophy after 38, 39 years of practice and placing over 18,000 implants that maintaining bone, maintaining that hard tissue is so important to me. I'm not a big believer in excessively removing bone. We've talked about this before because I know what's going to happen to our implants and the physical attributes that the patients are left with over 5, 10, 20, 30, almost 40 years now. And so maintaining bone is very important, not only for today, but for the future. And so the techniques that we use in extractions is as important as anything else that we're doing with implant dentistry. Socket preservation is critical. Our reflection design, our flap design is very important. For those of you who heard me before, I'm a big believer in maintaining soft tissue, not incising into mucosa. Many of us are trained to make vertical incisions to relieve the tissue. Once we incise into mucosa, that's where we run into a lot of problems. We have scar tissue, we have prostaglandin and histamine release. Patients are sore, they're hurting, and the experience is not positive. And so my flap design is very specific in almost every case. We're going to talk about bone grafting with a couple different materials. And if we're using an allograft material, and I use the allograft from Newport Biologics, which I get from Glidewell Direct, very, very high quality material. And the membrane I use, I have one membrane in my practice. It's a resorbable membrane, a long-term resorbable membrane, a 3 to 4 month membrane. But the technique that we must use to protect our allograft from invagination of epithelium is very important. Many of you have heard me say this. I can teach you how to grow bone. I'm going to say a very bold statement, 100% of the time. Facial plate and socket preservation. As long as you follow a specific protocol, no shortcuts, we can maintain and grow bone. And suturing is a very important part of what we do. There's some art to it. To get closure, we don't necessarily need primary closure. Epithelium is always going to grow a 0.5 millimeter to 1 millimeter a day. That's a physiologic reaction. As long as we properly design our reflection, if we properly place our graft material, a high quality graft material, and intrinsically place our membrane in a specific manner and suturing, follow up with the patients, we will provide an outstanding service for our patients. I am a big believer. I love doing immediate implant placement. I love one-stage surgical procedures if we're able to get proper torque. I love tissue maintenance. I'm not a real big immediate load person. Just from my experiences over the years, that's just me. I'm not judging any other speaker. I just find that I would rather let the implant integrate in most situations over time. It's like breaking your arm. You can put a cast on it, you can move it around, you can bang it, or if you have a broken arm and tell you, I'm just going to put an ace bandage on it, but don't use it. So I'm just going to give you some practical techniques of an immediate implant placement along with grafting. I think it's a pretty interesting case today. Grafting at the time of extraction is important. It'll help minimize bone loss. It helps support that soft tissue. To have interdental papilla, we must have interseptal bone. So we want to atraumatically remove teeth, maintain that interseptal bone, which will give us more aesthetics in the final restoration. It'll help prevent periodontal pathology, bone loss, shrinkage. We know physiologically that if we remove a tooth and we don't graft, bone is going to shrink. It's going to shrink down and in the lower jaw, up and in the upper jaw. And it allows me to predictably or adequately prepare a site and allows me to place an implant if we're going to stage our implant placement in a very short 3 to 4 months. And I can objectively determine the amount of integration of our graft material radiographically with our digital radiographs. Bone physiologically is going to heal from the apex towards the crest. And we're going to get more integration in that 3 or 4 months in the apical third. But again, if we're placing an implant, our initial stability with any implant is in the apical 2 millimeters. So I'm able to predictably, if we're staging, place an implant in a grafted site in a quick 3 or 4 months. If you're not grafting, doctors, you are going to get infiltration of soft tissue. Soft tissue grows 10 times faster than bone. Bone heals from the apex towards the crest. Tissue will grow from the crest into the socket, which will minimize our ability to place an implant in the future. We may need future grafting. And the literature will say we get 30 to 60% bone loss in a very short amount of time without grafting. So grafting is a very important part of implant dentistry today. I use a resorbable membrane, as I said, from Newport Biologics, very high quality. It's a 3 to 4 month membrane. I just need to protect my graft from invagination of epithelium for a 6-week window. And if I'm able to do that, if that membrane will remain intact and it's properly placed for 6 weeks, resorbable membrane, you will grow bone. The membrane that we're using is a purified intact collagen from porcine peritoneum, and it's very easy to manipulate and use. The graft material that we're going to demonstrate is cortical cancellous particulate. It's osteoconductive, and it allows for revascularization and integration in a very short amount of time and provides a foundation for our implant and implant restoration over time. Another material that I use is an osteogen material, again, available through Glidewell Direct. It's a bovine Achilles tendon, a calcium apatite material in a bovine Achilles tendon matrix. It's simple to use, inexpensive to use, and I would suggest in this program that we use it when we have all walls intact. We have a socket with all walls intact. If the facial wall is missing, I have a tendency to use my allograft with a high-quality resorbable membrane. With this material, for socket preservation, you don't need a membrane with that material. So let's get into the clinical. I know we don't have a lot of time together. So this was a patient. I was interviewed locally, and this was the assistant of the press person who had these teeth traumatized at a very young age. Obviously, she had endo. She was very, very anxious, didn't like the dental setting, did not use these teeth for many years. She was an adult at this stage. The teeth were slightly mobile, but she would never bite into an apple or a bagel using those front teeth. And at one point, she realized that she had to do something. So as your patients come into the practice, you obviously introduce yourself and talk about what you're able to provide this patient. I always give options. Obvious option number one is to do nothing, which is not really reasonable. The teeth were becoming symptomatic and problematic for her. We could remove the teeth and make a partial or a bridge. We could do conventional bridge work, or in today's environment, certainly we're going to discuss the possibility of dental implants and give this patient individual restorations in the premaxillary area. So we're evaluating those sites. You can see the maxillary left central incisor has significant bone loss facially and apically. There were apicoectomies were done. This poor person had gone through a lot of dentistry in her life. CBCT analysis is very critical, especially in the premaxillary area. Doctors, again, placement of our implant, and I like to say in my lectures, my failures with implants are because I place my implants too far facial. So we have to really understand the anatomy, the vital anatomy in the posterior mandible, the posterior maxilla, the sinus area. And in the premaxilla, we have to understand that we are never going to place this implant directly in the socket site. If we did that, we are going to have a very thin or no facial plate, or we could get a dehiscence. And we do see that still a lot in practices today. So understanding position of those implants is very, very important. I suggest that we reflect so that you can see the facial plate clearly, and it's very challenging or difficult to make a mistake in improperly placing that implant too far facially or not maintaining a facial plate for that patient. And just doing a virtual roundabout using our CBCT, we can kind of design removing that tooth. Now, where would you want to place that implant? Again, we're not placing it into the socket. Rather, we're placing it about 3 millimeters palatal to the facial aspect of the adjacent teeth to provide room for an abutment and a final crown. And you can see with the damage that we have there, we are going to get our initial stability of our Hahn dental implant in the apical portion of that available hard tissue. And again, we can use our CBCT analysis to help communicate with the patients. Some patients want to see what we're able to do and others do not, but we want to virtually design the case prior to any surgical intervention. When I was a young man, how I was trained. Visualize the case finish before you start. Well, that's an art that took me probably 10 years to master. In today's technology world, we're able to be all equals. You're able to take our technology and actually design not only the implant placement, but the final restoration prior to any surgical intervention. And here's our patient. You can see we have mobility, we have some trauma, we have some periodontal issues. She's very apprehensive about being to the dentist, neglect. Obviously, she's had dentistry done, and the crowns were done a long time ago. They were fine, but we did develop some mobility of those maxillary central incisors. So the first thing I'm going to do is we're going to anesthetize the area. We're going to infiltrate, and unfortunately, I am going to give a palatal. We try to make this as comfortable for the patient as possible. And after anesthesia, I'm just taking a simple periotome, not to loosen the periodontal ligaments or anything like that, rather to ensure that she has complete anesthesia. She's going to feel some pressure, but certainly should have no pain. Again, removing a tooth is emotional, both physically and mentally. So I'm trying to make this as positive experience for our patient as possible. So I'm simply evaluating anesthesia with our periotome. And this is an instrument that I love to use. Many of you are aware of it. Some of you may not be aware of it. It's called the physics forceps. And it's a simple set of 4 instruments. I'm not going to take a lot of time with this. A set of 4 instruments, if you can Google it, physics, P-H-Y, physics, S-I-C-S, forceps, series of 4 instruments, and it consists of 2 components. The beak is a shovel-shaped edge that engages the palatal aspect of the tooth, 1 to 3 millimeters subgingival. The second part of the instrument is called a bumper. It has a little silicone cover on it that's disposable, and it's placed as high up the vestibule as possible in this situation. And you're simply not squeezing the instrument. It's really not a forceps at all. It's really a class 1 lever. And I'm simply going to hold the handles of the instrument without squeezing. I'm just holding it with 2 fingers, and I'm going to rotate my wrist towards the nose or towards the nostril. I'm creating tension on the palatal aspect of this root, creating tension. That tension is going to result in another physiologic reaction. We're going to get an enzyme release, hyaluronidase, and it's going to break down the periodontal ligament. What's holding this tooth in place? The periodontal ligament. And by simply rotating, creating tension on the palatal aspect of this tooth, I'm going to rotate this tooth and luxate it up and out of the socket in a matter of seconds without any pressure. So the patients are having a atraumatic or minimally traumatic experience. The bumper is not the working end of the instrument. It is not holding the facial plate. It is simply acting as a center of rotation or a fulcrum point for this instrument to work. So I'm simply rotating my wrist, not squeezing the instrument, and the tooth will luxate up and out of the socket following that arc of rotation of this specially designed instrument. It is not intended to remove the tooth in total. Rather, I will take what I refer to as a tooth delivery instrument. It's simply a bird beak forceps, and I'm able to remove this tooth in a matter of seconds, atraumatically, minimally traumatically. To me, my hands, there's no forearm, there's no bicep, no neck, no shoulder. So if you have any manual dexterity issues with your hand, this is a great instrument. And we're simply going to remove both of these teeth. Now, we're evaluating the sockets. You can see there is some semblance of interdental papilla. There's inflammation there, obviously. And so it's very, very important that we understand interseptal bone, maintaining facial plate. We need at least 1 millimeter. I'd like 2 millimeters of facial bone on the facial aspect of our implant. So we're going to take a radiograph, make sure there's no root tips. I say this all the time. I see so many root tips left in the jaw. It's a little bit frustrating. So make sure you remove all the tooth from the site. And here I'm taking what's referred to as an Orban knife. It's a specially shaped blade, stainless steel blade, and I'm going to make a envelope reflection. I'm not making vertical incisions into mucosal tissue, as many of us would do. I want to control that reflection carefully. And as long as I am not incising into mucosa, I will not get prostaglandin and histamine release, and our patients don't experience a lot of discomfort. Postoperatively, 600 milligrams ibuprofen is routinely what I use, even in my full arch cases. As long as I'm not making vertical incisions into mucosa, we're able to control pain management really, really well. I'm making my incision and I'm going to make my reflection. Now, remember that maxillary left central incisor had no facial bone. There was granulation in there. There was an infection in there. The maxillary right central incisor, I have a facial plate and I can see it. I can see it with this envelope reflection. We're curetting the granulation. Curette, 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 curette. Purple blood is bad. Inflammation is bad. And we're going to evaluate the site that we have. Here's our Newport Biologic allograft material that I will wet with sterile water, sterile saline. Never use anesthetic to wet your graft. Anesthetic has a pH of 2, and it will inhibit or compromise the turnover of your allograft material, cortical cancellous allograft material in the site. So I'm simply wetting it, and I'm making it a gel. It's a putty. Here's my Newport Biologic collagen membrane, 3 to 4 month membrane, high quality, and I'm simply shaping it to the site. Now, it's imperative that this membrane be passively placed beyond the defect, at least 2 millimeters beyond any defect. Maxillary central incisor, we had big defect there. So I have to reflect with my envelope comfortably and place my membrane at least 2 millimeters beyond the defect. So here I'm using the Hahn implant system. I'm not going to teach how to place an implant, but basically we're using our primary drill, which gives me implant position. Remember what we said earlier through our 3D CBCT diagnosis. The implant is not placed in the socket, rather it's positioned 3 millimeters palatal to the facial aspect of our adjacent tooth, maintaining that facial plate. I'm going to measure, I'm going to evaluate, I'm going to take a radiograph. I'm using my apices of my adjacent teeth as a guide. When we're doing an immediate implant placement, I want that implant to be placed 1 millimeter subcrestal because we expect some bone shrinkage. Dr. Hahn created a wonderful implant with a 1 millimeter machine collar. It's designed for these particular situations. I'm going to widen the osteotomy. Again, I constantly check my position, stand up, look, buccal lingual, evaluate the facial plate, and my final implant placement will be 1 millimeter subcrestal. Again, I'm widening the osteotomy, and again, you can clearly see that I have a facial plate, and I'm going to torque my implant into position. We had a socket, and I was able to torque this implant to 45 Newton centimeters in a socket. Why? Because my initial stability, my torque is from the apical 2 millimeters of this specifically designed implant. I did the same thing with the maxillary left central incisor, and I'm going to cover with some cover screws, but I still have to address the facial defect on the maxillary left central incisor implant placement. You can see the threads are clearly exposed here. So I'm going to take my membrane. This is really important, doctors. I know we're running out of time, but I'm going to slow down. That membrane is critical. You want to use a membrane that will last at least 6 weeks. I'm using a 3 to 4 month Newport Biologic. And that membrane must be specifically positioned at least 2 millimeters beyond the defect. So doctors, you have to feel comfortable reflecting so you can see the apical portion of that defect. You can't force this. You can't guess. You have to know precisely the position of that membrane. I'm then taking my gel, my Newport Biologic cortical cancellous graft, and the membrane becomes my new facial wall. And I'm simply placing that graft material, making a new facial wall. Now, very important, we now have to take that resorbable membrane and I have to passively place it onto the palatal aspect, and that membrane must remain intact for at least 6 weeks. So this is the important part. Doctors, I know you know how to graft and I know you understand membranes, but oftentimes we force the membrane or the membrane comes out very quickly. Then the case becomes unpredictable. And I don't want you to have unpredictability. I want you to know that if you're grafting and you're using this technique, you will grow bone predictably. Suturing is very important, especially if we have a membrane. Now, most of us suture from facial to palatal. Now, when we're using a reverse cutting needle, when we're going from facial to palatal in this situation, oftentimes we will, because we have a reverse cutting needle, we'll grab onto that membrane because we can't see it. We know that we will remove the sutures, or your staff will, and if that needle penetrated through the membrane and the suture penetrated through the membrane, and you remove the suture, sometimes you remove that membrane along with it. That's unacceptable. It makes the case unpredictable. So the way I suture, the way I would like you to do it is I want you to be in control of the situation. So I will take my reverse cutting needle and I will go from crest and take that reverse cutting needle towards the facial. I can see that it's sliding over my membrane. Then I'm going to reverse that needle and I'm going to go from crestal, from the incision line, to the palatal. Again, I'm sliding over that membrane that was passively placed. I'm trying to respect the interdental papilla that we may have, that we will have interdental papilla alongside that interseptal bone. Our implants are 1 millimeter into the socket site, and we have closure. I don't care about primary closure, doctors. I've protected my allograft from invagination of epithelium, and this attached gingiva is going to grow about 0.5 millimeter a day. I don't care about primary closure. I don't care about primary closure. I'm using one long-term resorbable, high-quality resorbable membrane from Newport Biologics. I like to see my patients in a week. I want to see how they're maintaining it. I want to see the health of the tissue. Depending on the size of the defect, I may not have primary closure when I remove the sutures. But again, I explained to the patient, epithelium is going to grow physiologically 1 millimeter a day. And here I fabricated, I had a flipper made. This flipper is not resting on the soft tissue much, but I do have thickness of soft tissue. And again, we show the patient, we put a little soft liner in there, and the patient is able to leave with something. I would never immediately load this case, especially with the defect in the maxillary central incisor. 1 week post-op, you can see how the tissue heals remarkably, and I'm growing a facial wall. I'm going to allow these implants to integrate for 4 months. After 4 months, I will uncover. I will anesthetize the area where the cover screws are, and I will inject a little bit of septicane in that site. And I will take, some of us use a scalpel or a tissue punch. I'll use a round burr on a high speed with water, with like a number 8 burr. And I'll tell the patient, you're going to feel a little vibration. You're going to feel a little water. You may even hear a little sound if I touch the top of the cover screw. And it gives me a lot of control. Again, the middle photograph here is very, very important, doctors. You have a band of attached gingiva. Doctors, you must have a band of at least 2 millimeters of attached gingiva on the facial aspect of all your implants. So reflecting is important. Suturing is important. Placing the implants properly, 1 millimeter subcrestal. Placing the implant, suturing, and respecting interceptal bone, not removing valuable hard tissue, and realizing that you must have a band of attached gingiva. If you don't, another course that we can do on how to achieve attached gingiva on the facial aspect of your implants. Now, I've created this foundation for Alicia to fabricate implant retained crowns. So she fabricates custom abutments. And again, my implant position is very specific. It's not in the socket. I maintain at least 1 millimeter of facial plate. The implant is actually 3 millimeters palatal to the facial aspect of the adjacent teeth, which allows room for a custom abutment and the final zirconia bruxer crowns that will fit over the top. You can see my margins are always at or slightly subgingival, which allows for very good periodontal health. And we're able to see the patient beforehand. She had mobile teeth to final implant retained prostheses. We have a happy patient that is able to get on with her life, smile, eat foods that she hadn't eaten in probably 20 years, and improve the quality of life. Doctors, this treatment is in your wheelhouse. This is something that you're able to provide your patients with proper understanding and training. I'm a rules person. I pretty much do everything the same every day, and we get very predictable results that I want you to achieve also. So transitioning from what we had to atraumatically removing those teeth, evaluating the site, virtually designing our implants in proper position, not in the socket site, 3 millimeters palatal to the facial aspect of the adjacent teeth, leaving room for abutment and final bruxer crown, designing the final prostheses prior to any surgical intervention. You have complete and absolute control of what you're able to achieve for your patients predictably. We are now all equals in dentistry, and it just takes a little bit of time to be able to provide patients proper treatment. I'm going to stop here, Neil. We can always go through other cases in the future. And if there's any questions, I'd like to be able to answer them.
We do have some questions, and whenever anybody talks about grafting, we always get lots of questions. There's lots of materials out there, and there's lots of the same materials that have different names. So it always brings a lot of questions out. But let me start with this question, and this always seems to come up about the socket shield technique. And as you know, that's a situation where you leave a little bit of the tooth structure from the root of the remaining tooth, and that is supposed to help you to maintain whatever buccal bone you have left. Do you ever use that technique, and what are your thoughts about it?
Neil, yeah, that has been brought up many, many times with us, and I've seen many speakers talk about it, and it looks like an excellent technique. I'm sure it's technique sensitive with some special instruments, and I don't use that. What I've demonstrated here today, number one, the atraumatic, minimally traumatic technique, I'm able to save facial plate. I really respect hard tissue. You have to really understand extractions. We have a tendency to put a lot of force. We all know that dentist that puts the knee on the chest to take a tooth out. That dentist travels all around the country, I understand. So respecting bone is very important, but I feel very comfortable growing a facial plate. And I say I can teach people how to do it 100% of the time. So I don't know if I would use the shielding technique in this situation that I demonstrated with mobile teeth. I'm just not that versed in it. So I apologize that I'm not going to give you a good answer. If
Yeah,
that's a
I
technique that
mean,
works for you.
like you said, there's a few people that lecture around the country on this. One of the ways I judge is one particular guy who's a brilliant clinician, lectures on it, and every time I see him, he shows the same case. So
Ah,
it
okay.
makes me wonder how often he actually does it, or sometimes they have one case that comes out brilliantly, and they lecture on that for 15 years. So I
Time
don't
is
know.
very valuable. In my practice, time is so valuable. You know how many implants we do in a month,
Yeah.
and I'm a general dentist, so we do general dentistry too. So, time is valuable. So these techniques that we demonstrated here are pretty quick techniques.
Good. Um, and this is something that I know you lecture really well about. So there's a little question. Um, when do you use just an osteogen plug? When do you use just particulate bone? And when do you have to use a membrane on top of the particulate bone?
So number one, I use a high quality material, allograft, cortical cancer, Newport Biologic. That's all I have. Okay. And osteogen is a great material because it's inexpensive. So my rule here for our audience today is if you remove a tooth and you have a socket, a waffle cone with all the walls intact, I will use an osteogen plug. It's $40 or $50. Pack it firmly. It's not amalgam. You don't crush it, but it has to be placed firmly to the crest or slightly above the crest. And Neil, one thing I learned is if the socket's big, sometimes you have to use two pieces. And I know that's hard for dentists. You got to open up another $50. But if you're
That's
going to
right.
do it right, and it should be firmly in place. If you have a facial defect, what I do in my practice, I will use a high quality allograft material. I'll wet it with sterile water, sterile saline, and I will use a high quality resorbable membrane, the 3 to 4 month membrane from Newport Biologics. And what I demonstrated is that membrane has to be passively placed. It has to extend at least 2 millimeters beyond the defect, and it has to remain intact for at least 6 weeks. Anything short of that, it's unpredictable. Now, can we use osteogen in different situations? Of course we can, but for people with less experience here, those are my rules. If the facial defect is 5 millimeters or less, I have no problem using osteogen. I have no problem doing immediate implant placements, threading an implant into the graft material, or what I just showed here was grafting after the implants are placed, building that facial wall. So I have two materials and one membrane in my practice, and several sizes of sutures. I like the Vicryl polyglycolic acid sutures. Keep it
Do
simple.
you ever use particulate bone without a membrane?
No.
Okay. So
Now, if
so
if 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 I have a socket, if I have a waffle cone and all the walls in defect, and I decide to use an allograft and I'm threading my implant in place, I still want to protect the defect from the implant body to the natural bone, and I will use a Newport Biologics has a long-term collagen plug that lasts 3 weeks. Again, remember, physiologically, epithelium is going to grow half a millimeter a day. So, if I have a 5 millimeter opening, it's going to heal up in a week. Um, if they're smokers, I always try to protect it. But for a facial defect, like I showed here, no, you have to use a membrane or it's unpredictable.
great, great. We had a question here about Dr. Dennis Tarnow's ice cream cone membrane technique, and
Mhm.
basically that's what he's just trimming the portion that's tucked under the flap. Is that correct?
Yeah, or what he will often do is he'll put the membrane in the socket rather than outside. Yeah,
Okay.
inside the socket. So it as long as that membrane remains intact for 6 weeks, it becomes your new wall, essentially.
Got it. There's a lot of questions. When do you have to
That
tack the membrane in place?
again, I don't tack a lot. I probably have like 5, 6 different types of tacks in the office. But again, if we make that envelope reflection, I have complete control of that reflection, and I can tuck my membrane in there, and it will close up because I didn't make any vertical incisions. It's not floating all over, so that membrane is not going to go anywhere. So I don't necessarily have to tack it. I guess I would use tack like Dr. Resnick shows the bigger cases where he's growing a big facial plate in a edentulous posterior maxilla. Those are different situations. We're talking about a facial plate missing or a socket
Right, right. When you start looking at three walls and two wall
Exactly,
defects, yeah,
exactly,
where there's nothing to stabilize that graft. So
exactly.
that's there you go. Here's a good question. What do you do when the tooth that or teeth to be extracted are ankylosed?
Well, if they're ankylosed, you gotta grind them out. Neil, that's an interesting thing because when I teach it, you do a lot of clinical cases, and can I switch the question a little bit? What if we break a root tip and like 2-3 millimeters, that little teeny root tip is left in the socket, and what do we do as general dentists? We will take 35 minutes digging all different types of instruments, picks, and trying to find it. I don't bother doing that anymore. I just take away the facial wall. Grind out the facial wall, take out that little root tip, because I know I can grow a facial plate 100% of the time with the technique
Right.
that we demonstrated. So
So
it
rather than
echoes,
put the patient through a traumatic surgical
and your
extraction,
time is valuable.
yeah.
Time is valuable.
Okay. How long do you wait to place the implant if you used an osteogen plug versus the particulate? I mean, it sounds like sometimes you're still placing it the day of surgery, right?
A lot, yeah. If I can get initial stability, the only time I will, if I have active infection, purulence, I will curette, clean it out, and I will graft, but I won't put an implant in immediately. I love doing immediate implants, but let's say we have a socket, a maxillary molar or mandibular molar, where I'm not going to put the implant in the right spot. Um, I can use an osteogen or allograft with a membrane, and I will wait 3 to 4 months, and I will take a radiograph. Remember, physiologically, bone is going to integrate. It's going to turn over from the apex towards the crest. So the apical third is going to be better bone than the coronal 2/3. But my initial stability with my implant is in my apical 2 millimeters. So I can place the implant, and that bone is going to continue to integrate while the implant is healing.
Got it. Got it. Um, I have a lot of questions here about when can you go ahead and place the implant? In other words, if how big a defect can you have? How much buccal wall? I mean, but that's not really your decision point. Your decision point is can I stabilize the implant? Can I put a stable implant in there? Is there and
Yep.
that means is there enough native bone remaining, right, to
Yep.
allow you to stabilize that implant?
Maxillary molars, it's not in the aesthetic zone and it's three roots. We take the tooth out. Ideally, the palatal root would be the best one to put it in, but that's going to create aesthetic concerns. Um, I don't want to put it in the mesial facial root. I don't want to put it in the distal face. I want to put it in the center. So I will take that tooth out and graft it and let it heal and come back in 3 or 4 months and put an implant in ideally. Again, let's concentric circle. All I'm doing is creating a foundation so that Alicia at the lab can create a really nice restoration for me. So if you have to graft it, if you have to wait. We're all in a hurry today. I know everything wants to be immediate. Um, Mandibular molars, two roots, divergent. Take it out, graft it, let it heal, and put the implant in an ideal position in the aesthetic zone.
Yeah,
Sometimes it pays just to let things heal. Don't rush it, and get an ideal situation. It's the end result that matters, at Dr. Park. It's the end result. Not all the other timing doesn't really matter.
very good. Do you ever use non-resorbable membranes?
I know I do not, because our resorbable membranes, the one from Newport Biologics, is such high quality. It lasts 3 to 4 months. I only need a membrane there for 6 weeks, and I don't care
Yeah.
about primary closure. It's a great material. I don't like to have a lot of inventory. I want to get really, really good at what I do.
Very good, very good. I know now you're an expert with the diode laser, and here's a question about: do you use the diode laser for uncovering the implant?
Yes. Especially, that's again, great question. A lot of our patients are on blood thinners, not so much Plavix, but Eliquis, Coumadin, warfarin. And, we have to get consultations. You can't take a patient off a medication that you didn't prescribe. And oftentimes the physician or physician assistant will take them off 3 days before and they start the day. If we did that once, I'll use the laser and I don't get bleeding. So I love the laser, the diode laser to uncover. Just takes a little bit of extra time, but it gives me a lot of control. And again,
I've got a
maintain
question here
that
about whether the
attachment.
diode laser can enhance the healing
I will use a diode
during the
laser to help.
integration period. Is there
I,
some kind of laser technique for during the
you
healing
know,
period?
I that not the diode laser. I will use it to help sterilize the site. Where
Okay.
there's granulation. I will go in there and try to reduce the bacterial count in the socket. But I don't, I just reviewed an article on a UV light. They're actually using UV light on implants prior to placement, and they're seeing faster integration. Do you remember we've been around a long time? Implants weren't sterile when we got them, right? They came in your hand, and we would sterilize them. And I remember there was Dr. Mentag had some kind of UV light, and I remember we would treat the implants, and then we would put it in the socket, and the blood would just like soak up the implant. Remember that? I don't remember what it
Yeah.
was called. But what's old comes back again. So the diode laser I don't think is going to affect integration other than keep the bacterial count down.
Very good. Very good. So when you're placing the implant, and it's a situation where you're going to use an osteogen plug, do you ever place the plug first and thread the
Yes.
implant into the plug?
Yes. So with the osteogen, I love doing that. Okay. Firmly, not amalgam. And the implant will thread right into it beautifully. We'll get our initial stability in apical 2 millimeters. Now with allograft, because the particulate sizes are 250 to 1,000 and they're shaped differently, sometimes it's difficult to thread the implant and it'll bind. So when that happens, I take the implant out, I go back to my last drill, just go in and out real quick, and then thread it in. So yes, I will place the graft material and then thread the implant into position. Yes.
Very good. Okay, if you have you've placed a stable implant in the socket, there's a good facial plate remaining. Would you add bone to fill in the crestal portion?
The implant should, in an immediate socket site, should be 1 millimeter subcrestal. The literature says, when you have I'll tell my patients, you have a socket. We're going to remove your tooth. The socket is shaped like an egg. Everybody visualize an egg, but our implant is round. So we have a defect there. So our graft material is almost like caulking. The literature says if the distance from the implant body to the bone structure is 1 millimeter or less, you don't have to graft. If it's greater than that, grafting is probably a good idea. I routinely just graft. If I have a socket, I'm going to put a $50 oxygen plug in there and thread the implant into place, and you're just going to get predictable results.
Very good. I have a question here about guided surgery. In what situations would you use guided surgery?
Guided surgery is a remarkable tool. It adds to cost, but you need it when you need it. If you need to parallel implants, if you have vital anatomy that you're concerned with, all my full arch cases are obviously guided in today's environment. So it is a valuable tool to use, but it's not necessarily needed in every situation. I do a CT. Obviously, we just got the new one in. We're doing airways now. It's really awesome. I think I sent you some
Yeah,
pictures
you
of
sent
that.
me one yesterday. Yeah.
So it's pretty cool. But I use it. Is this a case that I want to do? Do I have enough bone to be able to place it predictably? Am I concerned with any anatomy? If I'm concerned with anatomy, then I will send it. I will scan it, send it to Glidewell, and they will help me determine if a guide is needed. All our guides today are bone level, but the guide is only as good as who made it. And doctors, when you take my courses, you'll hear me say you have to know how to do this two-dimensionally. You can't rely on a guide 100% because we make mistakes. I've made a lot of mistakes. My mistakes are because I put the implant too far facial. And a guide has to be very stable. A little discrepancy, a millimeter discrepancy in the posterior could be a 3 millimeter discrepancy in the anterior. So you have to know how to do this correctly. And all the CE that Glidewell provides, we train you how to do that really predictably.
Well, Tim, the questions just keep coming in. We'll be here all day, and I know that you and I both have some appointments right after this. So I'm going to let everybody go now. I'm going to let you go, Dr. Tim Kosinski. Thank you for a great lecture. You can judge by all the questions here that it's an important topic that people are really interested in. So we just might have you back for what,
We
maybe a
do.
14th or 15th time?
We
All
have them
right, we'll
scheduled
do it
back in
anytime.
March.
Anytime,
Coming
you know
back in
that.
March. Well, that's
Yeah,
quick. And
this will be
is
a
that
part
for a
two.
part two, or what's the topic then?
That's correct. It'll be a part two.
Excellent. Excellent, everybody. Okay, come back and see him. And then next week, we've got our friend Dr. Randy Resnick from the Resnick Institute, and he'll be talking about occlusion on implant restorations. So come back next week, see Dr. Randy Resnick and our wonderful business advisory panel, and we'll see you then. Thanks, everybody, and thank you, Dr. Tim Kosinski, for a great lecture. Take care.
Thanks for listening. Appreciate you.